Hello and welcome to the plenary session 202, the heterogeneity of Parkinson's disease. I am Ron Postuma and will be chairing my session along with my colleague friend, Professor Tan. I'm pleased to introduce the presenters for this session. First, Dr. Michelle Hu, who will be presenting on the evolution of Parkinson's disease subtypes from pre-motor to late disease stages. Then, Qin-Shen Lin, who will be defining Parkinson's disease subtypes according to their biomarker signature, and Dr. Connie Maris presenting precision medicine for Parkinson's disease subtypes.
At the conclusion of this session, participants should be able to better describe the evolution of Parkinson's disease subtypes from premotor to late disease stages, recognize Parkinson's disease subtypes according to their biomarker signature, and 3, discuss precision medicine for Parkinson's disease subtypes. Before we begin, I would like to remind all participants that the materials presented in the MDS Virtual Congress are for educational purposes only and are not to be recorded or reproduced. Photography of your screen or any presented content is not allowed. All relevant faculty disclosures for accredited scientific sessions can be found online at www.mdscongress.org. Please post your questions for the faculty in the live chat feature and be sure to stay until the end of this session for a live discussion and question and answer session. And finally, please take a moment to provide feedback in the session evaluation. You can find the link in the chat feature or in the scientific program tab on the Virtual Congress platform. Thank you and have a great session.
Thank you very much for asking me to talk on a tricky topic of the evolution of Parkinson's disease subtypes from premotor to later disease stages. My name is Michelle Hu. I am a clinical neuroscience professor and neurologist from Oxford. Why even attempt to clinically subtype Parkinson's? Clinical subtyping attempts a better understanding of the vast heterogeneity that we see among individuals with Parkinson's. In so doing, it might improve our understanding of the disease pathophysiology underlying Parkinson's, and it could allow clinical prognostication on an individual level basis. It might identify biological subtypes that could predict response, for example, to symptomatic treatments or disease-modifying therapies. However, subtyping is often being liable to methodological pitfalls and challenges. Typical examples include not measuring the same homogeneous patients at different disease stages, looking at a disease cross-sectionally and not longitudinally, having any lack of internal or external validation, having variable amounts of data collection across the different cohorts used. Clarity in statistical approaches is often lacking, and failure to link to biological disease markers is a key problem. In the future, it's very likely with digital intelligence and AI approaches that we're going to move from a group to an individual level fingerprinting approach for subtyping. So we're going to be moving from crude assumptions we might make across groups of subtypes to an individual. This is in the future. So what can we do now? So my talk today is going to start by focusing on work that we've done looking at baseline Parkinson's within the first year of diagnosis across 2 UK cohorts, tracking and discovery. We're then going to look as these individual patients progress over the next 6 years in their Parkinson's, and we're going to look at factors that affect baseline subtype stability and whether patients stay in the same subtype over time. And we're also going to look at whether there are any driving influences, such as the sleep disorder RBD, in that progression. And we're going to focus on data-driven approaches for these studies. I'm going to finish by thinking a bit about future analyses that might focus more on the prodromal or premotor subtyping of patients who have the sleep disorder RBD and have a very high risk of future conversion to Parkinson's and related synucleinopathies such as dementia with Lewy body. This study, which we started nearly 5 years ago now, combined 2 UK population ascertained cohorts called Tracking and Discovery. And the advantage of that is it allowed us to do validation work and discovery work from one cohort to the other. We used baseline and 3-year follow-up, and we were able to look at nearly 2,000, well, over 2,500 patients. We fitted our models of k-means cluster analysis to the tracking cohort, and we then used that to predict clusters in the discovery cohort. We included a number of clinical measures across different domains, such as motor, non-motor, and cognitive function, and we looked at levodopa response in a subgroup of patients who had a formal levodopa challenge at their 18-month visit. So each visit is happening at 18 months. And as you can see from table 1, we have quite similar matched demographic and clinical characteristics across the 2 cohorts. These are patients who are not selected on the basis of age, a genetic cause of Parkinson's, but they are simply patients known to their secondary care Parkinson nurse or specialist who were able to come to their local clinic. Notably, these patients are significantly younger than other leading biomarker cohorts such as PPMI, and their MOCA scores of around 25 are also lower, which is very common in these unselected cohorts. So we think that this represents what's really out there living in the community with Parkinson's. I'm going to explain this bullseye picture by starting on the outer rim here. The outer rim focuses on baseline motor features in these subtypes that were identified using k-means cluster by Michael Lawton. The next ring looks at baseline non-motor function and divides it into average, better than average, severe or prominent. The next ring looks at levodopa response on those patients who had a levodopa challenge test. And then in the inner ring, we look at motor progression in the next 3 years after the baseline visit. The 4 clusters that we identified can be broadly summarized. Firstly, cluster 3, which was present in 21% of the combined Parkinson cohort. These are patients who have very severe baseline motor, non-motor function. Their baseline motor is more gait and posturally driven. They need higher doses of medication for symptom benefit, and they have a worse motor grade. Cluster 3 also has marked non-motor symptoms at baseline. They have very severe psychological well-being and sleep disturbance. However, their levodopa response is intermediate, and their motor progression subsequently is not very fast, it's intermediate. The next cluster 2 are patients that you see in clinic who you wonder if you've got that Parkinson's diagnosis right, because they seem to be doing better than average across all of the measures. And these occupy around 1/3 of our Parkinson patients at baseline. Cluster 4 represents patients who have a tremor dominant phenotype of Parkinson's. These patients have predominant tremor as their motor symptom, they're unilateral, and they have only average non-motor baseline symptoms, and their levodopa response is poor because in general, tremor doesn't respond well to levodopa. And then we have lastly, cluster 1, which is distinguished by prominent non-motor features, which are severe, a symmetrical baseline motor phenotype, and suboptimal response to levodopa. So this is the baseline phenotypes. What happens when we look at the subsequent progression of each cluster over the next 3 years? And here what we've done is that we've looked at the annualized change in the motor function measured with MDS-UPDRS-3 per year. And what we can see is that in the tracking cohort on the left and the discovery on the right, there is remarkable similarity, and that we can see that clusters 1 and 2 have the highest rates of annualized motor progression in both tracking and discovery. Is this relevant to clinical practice? Well, I would argue that yes, it is. Because if you take simply the difference between the fastest and slowest motor progressors in both cohorts, we see this is 3 motor UPDRS points a year, which is equivalent to a clinically meaningful PD trial endpoint that is currently being used in many studies. Therefore, if you fail to account for this baseline heterogeneity, through simple selection bias, you may have a false positive or a false negative result to either symptomatic or disease-modifying treatment. Is there any evidence of biological relevance or biological validity to these underlying PD subtypes? We have been able to show this in 2 particular examples. Firstly, we've been able to show that if you measure routine serum analytes in the baseline clusters, which we did in over 900 of our PD patients, we see that there is a pro-inflammatory response in the worst baseline cluster, cluster 3. And this is seen by a significantly elevated apolipoprotein A1 and an elevated C-reactive protein. These data have been adjusted for age, gender, and disease duration and published in Movement Disorders last year. However, the other analytes, which on a literature review had been shown previously to be significant for PD progression, such as uric acid and vitamin D, failed to reach statistical correction. We've also subsequently shown, or Michael Lawton has shown, that genetics of the different Parkinson's subtypes vary. In his methodological approach, what Michael did was to combine the tracking and discovery cohorts and to compare rates of LRRK2 and GBA mutations against the baseline subtypes. He then calculated the genetic risk scores for Parkinson's, MSA, PSP, dementia Lewy body, and Alzheimer's, and then regressed these against the probability of belonging to a baseline subtype. And lastly, he performed a separate GWAS study to look to whether belonging to a PD subtype also varied. The results showed that, in fact, the most severe baseline subtype had the highest rates of GBA mutations compared to the mildest disease subtype, which had the lowest rates. And GBA is increasingly implicated in causing a more severe motor and cognitive phenotype, as well as a younger age of onset. Using genetic risk scores, Michael looked and found that the genetic PD risk was interestingly positively associated with the mildest clusters 2 and 4, seen here in this scatter plot on the right. However, the more severe subtype 3 had reduced PD genetic risk. And this may be because some of these patients have a more atypical phenotype, or because few GWAS studies to date have actually looked at community ascertained PD cases. Lastly, in the GWAS study, Michael did not find that any individual SNP variants met genome-wide significance. We then worked with our funder, Parkinson's UK, and an AI company to explore the tracking and discovery baseline data to see if we could validate our existing baseline cluster model. And also, as 3 years had elapsed since the initial longitudinal analysis, we then looked at the longitudinal data over the next 6 years across both cohorts to better understand progression rates of the clusters and how robust they were over time. In our methods, the initial phase 1 models were trained on tracking data with discovery used to validate outcomes. And then we subsequently decided to combine data variables that were common across tracking and discovery into one single data set, which were reduced to 21 variables to be able to show common data and predictive models across both cohorts. The variables were configured into 3 groups, showing motor, non-motor, and cognitive or mood subdomains shown here. Principal component analysis aims to find groups of individuals where who have closely correlated variables. And the principal components that are found is aiming to find these variables that are as uncorrelated or as separately apart as possible, so that they capture the greatest degree of variance across the data set. The first principal component 1 will explain the highest amount of variability, followed by principal component 2, and so on. And here we are simply plotting principal component 1 and 2 against each other in this combined cohort dataset, having found 28 components in total. Principal component 1 and 2 contribute to 21% of the variance in the dataset. And here we see a big blob of data with no clear subtypes emerging. If, however, you go on and project these blobs with the two principal components back projecting onto the baseline clusters from 2018, you do start to see that there are clusters, and indeed there are 4 clusters shown here across the 4 quadrants 1 to 4. These clusters moderately correlate with the original baseline phenotypic clusters that Michael Lawton derived. We then projected these baseline clusters onto the combined tracking and discovery cohort shown here. And we again plot the PCA map here, now accounting for around 27% of the whole variance in the data set. And we can see variable rates of the different subtypes, which here are color-coded with cluster 1 in brown, cluster 2 in red, cluster 3, the more severe cluster, in green, and cluster 4 in purple. Now, to persuade you that there is reasonable correlation, we need to show you biplots of the principal components. So just bear with me here. What the red arrows are showing the directionality of particular phenotypic domains, and in particular non-motor, shown in the top right quadrant here, is outlining a number of severe non-motor symptom traits, including anxiety, impulsivity, compulsive disorder, fatigue, depression, sleep encompassed by RBD and sleepiness, and a number of other features that you can see. Now, the directionality is such that when you increase your score on these questionnaires, you do worse in the non-motor domain, but conversely, the opposite also applies. So in this bottom left quadrant, you would have good non-motor function overall. Looking at the bottom right, the main arrows or features here deal with motor function delineated through the UPDRS, but also things like the postural blood pressure drop and cognitive function, because in the top left you see good cognition, which is evidenced by high scores on the MOCA and semantic fluencies. Therefore, the converse, which is poor cognitive ability, is actually present in the bottom right quadrant. So that gives you a rough overview of the principal component maps. If I now attempt to map on the 4 baseline clusters onto the PCA components, I will start by looking at cluster 3. If you remember, this one had the most severe non-motor and motor features, with in particular psychological well-being and sleep being poorly affected. If we look on the right to the PCA component, cluster 3 here is shown by the green dots, which are to the right of the y-axis. Here you see then that the green, or cluster 3, are particularly featuring severe non-motor, cognitive and motor ability, as well as postural drop. So this is very consistent with what we're seeing, and we're seeing that the motor problems are axial, i.e. their UPDRS postural and speech, in addition to general rigidity and bradykinesia. Cluster 2, I believe, is also well explained by the PCA model, because this one did better than average across all of the domains. And here we see that cluster 2, shown here as the red dots, belongs in the top left quadrant here, which is quadrant 2, who have good cognitive ability, good motor ability. Where the model doesn't perform so well is in distinguishing the tremor dominant cluster from which is cluster 4 from cluster 1, who have prominent hyposmia and cognitive impairment with symmetrical motor disease. And it may be that the principal component analysis is pointing more towards a 3-cluster solution, which we're currently looking at. Interestingly, you can also look at the PCA maps by dividing them into the different domains. So here we see in the top left, the overall, all the features combined. We also then see the motor principal component map, followed by the non-motor and the cognitive mood. And again, we see that cluster 3 tends to be towards the right in the motor, cognitive mood and all domains, but in the non-motor, the severity goes, instead of left to right, from right to left. And this is simply the way that the principal component analysis has derived the factors. The maps here show this in a similar way, where we can see that in the vast majority, progression in motor, non-motor features is driving you towards the right, and in particular towards the bottom right, whereas non-motor progression is going towards the left. Now, the very interesting thing was then what Greenhouse Intelligence did was take all of the baseline clusters, each dot represents one cohort member, and then they plotted how their principal component factors varied over time with visit. So here you see baseline visit, then you see visit 1, visit 2, visit 3, and visit 4. And what we generally see is that firstly, the original tight clustering of dots fragments over time and individuals become more separated. The original clusters therefore disintegrate and become less meaningful, and that there's a general progression in all of the clusters other than cluster 3 to get more severe, moving to the right and in particular moving down to the right, so that they start to approach where cluster 3 started off at. So we can also look at this by combining principal component 1 and 2 into a compound vector. So now instead of looking at multiple axes, we're just simply looking at the progression of component 1 and 2 on how far they're moving from left to right. And interestingly, here at baseline visit, which is the number 1, everyone is to the left. But we see that the worst or more severe cluster here is already out there as being the worst. So at baseline, cluster 3 is out to the right. What then happens is that the other clusters start to progress more quickly, in particular clusters 1 and 2, who are the red and green clusters, and they start to approach the severity of cluster 3 or catch up. But ultimately, cluster 3, which is the most severe, starts off as the worst. It probably progresses the least, but it remains the most severe by 6 years of progression and follow-up. So just to summarize that one more time, at the baseline visit now and 1, we see cluster 3 way out as the most severe already on both principal components, and then the other clusters start to catch up, but don't quite make it to be as severe as the original baseline. And when we start to look at the individual components by cluster, we see this in a similar way. So for example, the motor deterioration is driven by baseline clusters 1 and 2, with the green dots shown here. Similarly, the cognitive and mood is again driven, the rates of change are driven by clusters 1 and 2, whereas cluster 3 starts off badly and in the non-motor domain in particular, and it ends badly. So when we look at the original subtypes, again, we see that this is consistent in that it is predominantly clusters 1 and 2 that have the fastest motor progression and also the fastest non-motor progression. So it's these two baseline clusters 1 and 2 that progress the most, but actually start off not being so severely affected. So maybe Parkinson's heterogeneity is simply a matter of degree in which you present in terms of underlying pathology. If you present already very severe, you're going to start severe and remain severe. If you present as mild, you're going to catch up as your disease progresses over your duration as the pathology progresses. So to summarize key findings so far, we've used data-driven approaches in over 2,500 patients. We've shown using K-means cluster that there are 4 baseline clusters shown here. And we've shown that there is reasonable reproduction of these 4 baseline clusters, although there is a suggestion of a 3-cluster model fitting better using alternative PCA and AI approaches. We've shown that there is some evidence of biological validity with a pro-inflammatory response and different genetic profiling of our 4 baseline clusters, in particular relevant to the worst baseline cluster 3. However, the longitudinal analysis has shown that over time, these clusters disintegrate and there's a general tendency for individuals to progress and move towards the worst effective baseline cluster. For future work, which is now ongoing, is also going to include the younger PPMI cohort who are less cognitively impaired and who are importantly drug naive, because of course levodopa treatment is likely to play a big factor in the clusters, and we only have 10% on average of our tracking discovery cohorts that were unmedicated at baseline visit. Changing track now, I'd like to just end by thinking about the role of RBD, which is a sleep disorder during REM phase where patients move and enact their dreams. And our original cluster analysis showed that this severe baseline cluster 3 was earmarked by very severe psychological well-being and sleep, and that RBD, increased severity of concomitant RBD, was associated with increased daytime sleepiness and psychological well-being. So here we said, we're no longer interested in taking all the variables in a data-driven approach. Let's just look with an a priori hypothesis that RBD in itself, if you have it early in your course of your Parkinson's, modulates progression subsequently. And this work was led by Yaping Liu, who was a fellowship student with me from Chinese University, Hong Kong, and Michael Lawton. So here what we did was take 923 early PD patients from discovery. We used both baseline and longitudinal follow-up data. We determined possible RBD by using an RBD screening questionnaire cut point of greater or equal to 6, but that had to be present at 2 occasions at least, at baseline and subsequently, to reduce false positive diagnoses of RBD. And instead of principal component or K-means cluster, we simply used linear mixed effects and Cox regression models. At baseline, within a year of diagnosis, we found that 33% of Parkinson patients had concomitant possible RBD, and they were very representative of our general PD population in age and gender and gender male to female predominance. The first main finding is that at baseline, PD with concomitant RBD do worse. They have worse non-motor function at baseline, shown here across MDS-UPDRS-1, Epworth Sleep Scale, the depression inventory, the anxiety inventory, and also things like the Montreal Cognitive Assessment and the MMSE. Subsequent non-motor progression is also worse using the depression inventory and the UPDRS motor part 1 scores in those with RBD versus those without. And graphically here, those with RBD are shown here as red and those without RBD as green. What about motor progression? Well, similarly, we see that motor progression is worse in those who have PD plus RBD, shown here as the red boxes, but it's also worse at baseline in these PD patients who have RBD. And that's shown through the MDS-UPDRS-2 score and in the Flamingo balance test. We have evidence for worse motor progression, which is just significant in the Purdue pegboard rate of deterioration and the decline in UPDRS-3 and UPDRS-2 scores. And lastly, which is clinically, I think, very relevant, patients with possible RBD at their baseline within a year of PD diagnosis have a higher risk of future gait freezing, frequent falls, and mild cognitive impairment, with hazard ratios ranging from around 1.4 to 1.6. So this is very relevant in terms of counselling patients about future bone health exercise, adaptations and OT in the home, and potentially looking at dementia interventions that might be effective in this subgroup. We also worked with the AI intelligence team who replicated this finding, and here what you're seeing is that the PD patients with RBD, shown here in the green dots, start off at their baseline visit worse off in the principal components, and they progress more quickly. And this was present and just significant for non-motor phenotype progression, and just failed to reach significance for the motor progression. So we're able to show similar results with both differing approaches in statistics. So the key finding of this study is that if you have early Parkinson's within a year of diagnosis and additional concomitant possible RBD, which is very easily screened for on a readily available screening questionnaire, you are likely to progress faster in terms of your motor, your mood and cognitive symptoms, and that RBD may well be confirming a more aggressive PD subtype that has been shown in other studies, and it has major clinical implications. So lastly, how about future work? Where do I think we might want to focus and look at? I think it would be really interesting to look with these approaches at the RBD phenotype prior to these premotor or prodromal individuals having phenoconverted. Currently, we're limited by small numbers of PSG diagnosed RBD patients in the discovery cohort of around 300. However, Ron, and I know you're listening, I would argue that future work needs to focus on combining several well-phenotyped RBD cohorts, all PSG diagnosed with similar levels of longitudinal follow-up and phenotyping, applying these data-driven approaches, and then looking at the RBD subtypes prior to phenoconversion. We would like to do this particularly by comparing it to the PPMI phenotype, because they're drug naive, as are the RBD patients, but also the tracking and discovery cohorts, and potentially a dementia with Lewy body cohort, because I would argue that if you can actually predict using this phenotyping approach which patient with RBD will go on to phenoconvert and what they'll phenoconvert to, whether it be PD or dementia with Lewy body, this is going to improve your future trial stratification, because we are going to be seeing neuroprotective trials coming out to intervene at this earlier disease stage. So I'd just like to finish by thanking all of the clinical cohort team shown here who made this work possible. We have now